In this session, I'm going to look at some of the similarities and differences in dealing with COVID-19 across a number of jurisdictions. The point that comes through is that there is no one-size-fits-all approach. However, distinct ways of dealing with the coronavirus in the absence of a vaccine yield comparable results. I'm going to turn to the characteristics of successful track and trace systems before ending with a regulatory analysis of the ways to compare these distinct approaches in a form that can permit greater economic interaction between countries. We have heard from Katina about the differences in the approaches used to discover contacts based on apps. I'm going to be looking at what is done with that contact information. I'm going to draw upon the work by Dr. Jennifer Summers and her co-authors published in The Lancet in October 2020 regarding New Zealand and Taiwan. I'm also going to leverage on the work conducted by Australia's chief scientist, Dr. Alan Finkel. One of the challenges of contact identification and tracing is a cultural one. Some of these cultural issues are very recent. For example, Taiwan had to deal with the 2003 SARS pandemic. This means that epidemic responses, including social distancing, mask wearing, and hand hygiene, were well understood at the start of the COVID outbreak. The response in Taiwan was to identify those with COVID-19 by testing and to have strict 14-day quarantine for them, their contacts, and for international arrivals. Taiwan did not have a lockdown, but did have one of the lowest rates of infections, measured in infections per million population, in the world. Singapore had a similar approach, but did need short lockdowns or circuit breakers to prevent spread. Singapore adopted mass testing, that is, testing for people not showing symptoms, and has the lowest death rate per case. New Zealand had a hard lockdown with the aim of elimination rather than suppression of the virus. In Australia, all states imposed lockdowns with the aim of suppression rather than elimination. In Australia, as in common with New Zealand, the major sources of domestic transmission arose from failures in the international quarantine process. In each country, reported potential and confirmed outbreaks and clusters prompted public health officials to put in place similar infection control procedures. These included contact tracing, testing and isolation of cases, and quarantine of close contacts. All jurisdictions provided social and financial support during the COVID-19 pandemic. They also have existing universal health coverage. In all of the countries, COVID testing was free. In Australia and New Zealand, it was restricted to people with symptoms, but these symptoms could be very mild. At the heart of the actions in each jurisdiction was test, track and trace. The Australian view is that a fully digital contact tracing system can dramatically improve the efficiencies of contact tracing, but will never replace the need for well-trained contact tracers and expert public health oversight. It's not easy. There needs to be ongoing and consistent investment in public health expertise, including at a local level. Decentralised contact tracing teams need access to centralised technology for case allocation, interviews, and particularly outbreak management. In an ideal world, public health units are embedded into the lowest local health district. There also needs to be clear governance with very precisely articulated, non-conflicting leadership roles. This needs a well-functioning crisis command centre in which experts from multiple agencies can work collaboratively to coordinate responses. There also needs to be surge capacity. This is where digital systems win, as they facilitate the secure training and onboarding of a surge workforce. The surge testing capability, the Australian experience finds, should be at least 3,000 tests per million population per day. Surveillance, such as wastewater testing, helps in identification of potential clusters. It forms an adjunct to test, track and trace. As well as testing, rapid whole genome sequences of the viral genome and serological antibody testing must be integrated into upstream contact tracing. The overriding intention of end-to-end contact tracing is to never fall behind. It also means that confirmed cases have to be strictly isolated, either at home, in a hospital, or some other supervised location. This is easiest done by having a dedicated case manager. When there is an outbreak, there needs to be every effort made to go hard and go early. In addition, communication needs to be culturally and linguistically appropriate. So, I argue and suggest that the evidence supports the proposition that technological characteristics to work out who contacts are, whether using an app or pen and paper and memory, is not the major determining factor. What is important is that the track and trace system needs to identify COVID positive cases within about 24 hours of the case being identified. Further, that identification of a positive case needs to occur within about 24 hours of testing. These times are consistent with the epidemiology of the current strains of the virus. Subsequent levels of contact do not have as critical a time frame, but any locations of large groups and potential mass contagion need to be identified promptly. In turn, this leads to an issue. Testing rates will be limited by the number of staff at one end and the number of people seeking tests at the other. Generally, the rate will be close to a constant for any test facility during its opening hours. However, if sample analysis is done on a batch basis, this may be problematic in meeting the key performance indicators I've suggested. I come from a background of research in regulation. This means I'm going to suggest a characterization which is called equivalence of outcomes. Equivalence of outcomes means that for the same inputs, a specific result is obtained. Importantly, it does not mean equivalence of inputs. The outcome does not matter whether the contacts are identified with an app, whether that app's centralized or decentralized, or by memory prompts. It also does not mean equivalence of outputs. The format of reporting is entirely irrelevant. Instead, it means that the same isolation of a positive patient and their contacts occurs as a result of any infection. So, why would I suggest the idea of equivalence of outcomes? Well, the answer is that by having equivalence of outcomes, states within a federation and countries can understand how each other will deal with an outbreak. It can be used to determine when travel is reasonably safe and when it should be avoided. That is, measuring using equivalence of outcomes has the potential to open up some of the economy. For example, in each of Australia and New Zealand, the agricultural sector relies on Pacific Island seasonal workers. For any specific Pacific Island, If testing and tracing procedures produce the equivalent outcome to either Australia or New Zealand, then travel becomes possible without the need for quarantine on arrival. Australia, faced with the challenges of a federal system of government, has struggled with even defining an outbreak at a national level. However, effective test, track and trace, often based on commercial customer relationship management software, such as Salesforce, provides the best opportunity for economic recovery and opening of borders. So, I've shown that there are distinct approaches to dealing with the pandemic. However, at their heart, they all have effective track and trace based on large-scale rapid result testing and subsequent isolation. Once we can characterize the outcomes of the actions using the regulatory concept of equivalence of outcomes, then there is the prospect of opening borders. Thank you.
So Rob, you seem less focused at this point on the underlying technologies. Surely the track and trace system, whether it's built on a system such as Salesforce or bespoke, needs to be software-based. Is that not true?
The real issue with having it software-based is to be able to surge. So if you're using Salesforce, then training people outside of the people who are actually doing the work is possible. It becomes more difficult with a bespoke system because it's likely that those involved in developing the bespoke system are also involved in operations. So that may limit surge. There's also a cautionary tale that comes from the UK where Excel was being used to transfer data. That's fine, except that one person with a very large spreadsheet saved the spreadsheet as a .xls instead of a .xlx, and 16,000 cases were not tracked and traced as a result. So having a software system which has clear interfaces, ideally available application programming interfaces, but an understood interface, and with a training mechanism outside of disturbing operations is really key.
So what's the best way to communicate with contacts, once they're identified? And what lessons have we learned in Australia, for instance?
Okay, so sending a text is a great way of sending information that people will respond to quickly. But in the Australian context, so Australia is a multicultural society. Up to about 30% of all of the population is first-generation migrant, like me. And the issue comes there, if a text is sent in English, English might be the second or third language of the person who receives it. And likely in an environment where there are scam texts and phishing, people are going to be quite distrusting of texts. So making sure that text information is sent in an appropriate language is really important. But that gets to be quite difficult because then it means that part of the data collection associated with testing might also include collecting information that wouldn't normally be asked, like what language do you speak at home? What language do your contacts speak? It becomes quite problematic in terms of acquiring much more data than is necessary just to deal with the health issues.
You mentioned equivalence of outcomes. How do you measure or test whether this idea is being carried out in the field?
And it's a difficult one because ultimately it requires each jurisdiction to be able to say, this is what our outcomes are in response to a particular input. So if we know that there is a person who has tested positive that has spent more than an hour at a shopping mall, does that mean that all of the people in that shopping mall are considered as close contacts? And if they're close contacts, they should self-isolate and get tested? Or does it mean they're casual contacts? If they're casual contacts, they should monitor for symptoms, but otherwise not self-isolate. So it's having a clear set of these are the outcomes for a specific input. And it also means that there is consistency of things like assumptions of incubation period. So isolation, is it 7 days, 10 days, or 14 days? So in Australia, we say it should be 14 days, test it within 2 days, ideally another test at 11 days. And if the second test is negative, then continue the quarantine to 14 days and it's over. But other countries are looking at potentially shorter quarantine periods. So the equivalence comes from knowing that there is also the same response to a particular test configuration.
And finally, do you think a country will risk the health of its citizens on the assurances of a foreign state?
I think that's the hardest problem of them all. And I think the answer is probably yes. And the example that I would give would be initially Singapore and Hong Kong, where each state agreed that a travel bubble could be opened when certain thresholds were met. Now, sadly, those thresholds weren't met in 2020. I think there's another one, an example between Australia and New Zealand. Now, Australia trusts New Zealand, and New Zealand has a lower rate of cases, so travel from New Zealand to Australia is possible without quarantining on arrival. But New Zealand does trust Australia, but is anxious about the number of cases, and therefore the travel is not reciprocal or was not reciprocal in December 2020. So states can rely on trust, but that trust needs to be based on the medical evidence and a real understanding of what is meant in each of the two countries by different things, including the idea of incubation, including all of the outcomes for which I'd recommend equivalence.
Well, thank you. Thank you.
Thanks, Joe.